with what went on or what you thought what the diagnosis was? Because if you were witnessing the encounter, what were some of the big points that helped you come to a diagnosis? If you were to present this to myself, I guess, and I'm in the preceptor room, what information would you give me about this patient?
Suprapubic pain.
Mm-hmm.
Oh, you're talking about the second visit?
No, both visits.
Okay.
So we'll go with the first visit first.
Dysuria and suprapubic pain.
What else?
A young female.
Okay.
Sexually active.
Okay.
And then like negatives, like no fever, chills, vomiting.
Mm-hmm.
And CV tenderness.
Okay.
Yeah, no history of like urinary tract infections or STD. She's using birth control.
Okay. And then we have a lab result. So which helps you come to the conclusion of what are you thinking from the first encounter was your assessment?
Uncomplicated UTI.
Fair. And then treatment was what? Did anyone change treatment? Did you do something differently?
For macrobid is like the first line for females of that age. So like macrobid for 7 days.
7 to 10 days would be appropriate. All right.
Bachelor for 3 days is also appropriate.
It is. It's an alternative first line as well. What would your thought be about? So, are you worried about this patient at all?
After the first encounter, probably.
And why not?
Stable. Vitals were okay.
Uncomplicated.
Yeah, and she came in like after 2 days of symptoms, which makes me think she's like, and she's been taking her medications.
So,
Health literacy.
health literacy was pretty high. All right. So, I guess going forward, you have the first encounter, hopefully uncomplicated UTI, as you were saying. What about when she comes back? With it 3 days later?
Yeah.
What are your thoughts about that? Before you even go into the room, you have a patient that you treated for a UTI, and then they come back. What are your thoughts?
Where's my urine culture sensitivity?
Yeah.
Okay, all right, fair enough. So those were provided, and then your thoughts from then on out.
Better change the antibiotic.
What's going through your mind in terms of differential? Anything else? Yeah. Okay, PID. Okay, that's fair as well. What'd you say? I mean,
Just kidding.
probably not high, but could be in there. So, all right. So, based on that, what do you want to do? What's your plan?
Well, there's definitely a positive culture,
Mhm.
so there's likely that's what's causing it. But then you have to determine, is this patient sick enough that they need to go to get IV fluids every recession, IV antibiotics and everything.
Or vitals?
Temperature 100.0, I think her heart rate was over 90.
95.
Respiratory rate was like 16.
16.
She was nauseous.
Your white cell count.
And her blood pressure was?
90 over 60. But that's her baseline.
So, I'm in the preceptor room.
Yeah.
You're gonna tell me, I ask you the question, sick or not sick?
Sick.
Okay. sick enough to go to the ER, sick enough to treat as an outpatient.
Borderline, because if it's a kidney stone, we have no imaging that I can do right there.
Okay.
We can't technically exactly differentiate between those two.
So I guess who would treat her as an outpatient, see how she does, who would send her?
I would send her.
I think originally I was gonna shoot her outpatient. Yeah, and then Bo was like, do I need to go to the ED? I guess you.
I should not ask that
So
question.
if you were gonna treat her, I guess, again, with every decision, you should have a rationale for why you're making that decision. So if you're
Yeah.
gonna treat her as an outpatient, and there's no right or wrong answer to this one was purposely oriented to be right on the borderline. So I guess why would you, for those that would treat her as an outpatient, why would you think about?
Because we gave the wrong antibiotic. So I would like try with antibiotics first, at least a day or two.
Mm.
I mean, if you have sensitivities, then you could probably feel safe treating as an outpatient, but if you don't know what it's sensitive to, you could have like a repeat failure.
Yeah, I don't think she needs to urgently go to the ER. Like, if she goes and gets her script and takes it and continues to get worse, then you could advise her to go to the ER. Like, but she doesn't have a fever. Vitals are stable. Like, the ER, what would they do?
They'd
Give her a
probably
script.
send her home, yeah. with a
Give her
script.
the same, like,
Sure.
After
Now
they
she's
get
got,
CT
but now she's
scan.
got an extra bill too.
Yeah, now she
That's
was like
true.
down.
Okay, so you're considering cost within this.
And her time. I
Time,
mean,
cost.
I'd be mad if
She's
she
got no
don't.
previous urologic abnormalities that would predispose her to pyelonephritis from what I understood. She's got no history of these that are recurrent, so I don't, she's got many resistance built up to it. She's not septic, things are baseline. Get a W white blood cell count and check that out. If that's an astronomical number, we could probably send her in after that, but as long as she's stable at this time, with a quick follow-up to see how she's doing in the next 48 hours, is what I would do.
So imagine this is Friday afternoon. Doesn't change anything.
That's my thing. I feel like in like the resident clinic space, there is no white blood cell count. I'm not fully comfortable because even with pyelonephritis, you need to follow up within 48 hours. And I don't have a white blood cell count. I'm not just comfortable with letting her just go like that without having all the blood tests that I would need to feel comfortable there. So
Okay. Would you, I guess, considering how high on your differential is nephrolithiasis within this? It was brought up, so I'm just kind of picking your brains a little bit.
No blood, no pancreatic, no groin.
What'd you say?
No
There's no
history of
blood.
stones. Her family history of stones. I mean, it's possible it's causing her UTI. We don't really know why she's
She
got a
wasn't.
UTI.
She didn't originally present getting comfortable. If anything, it'd be an infected stone,
Yeah.
which that would be much different.
Didn't she?
So I guess how do you deal with possibility versus likelihood?
Get an
In these.
ultrasound.
So do you,
But I mean, symptomatically, she doesn't appear to have this stone. Which is, I think we have pretty clear cut diagnosis.
alright, so she had the right CVA tenderness. Her vitals are not the best, but not febrile. But she may be approaching that. She doesn't look septic, so.
Pyelonephritis is not automatic admission.
No, it's not.
Mm-mm, no,
yeah.
not at all. So if you were to treat her as an outpatient, what would you treat her with?
Or equivalent.
And what dosage and for how long?
750. Like daily for at least a minute.
What would
That's it, well, long so be Cipro. So Levo.
Don't we have susceptibilities too?
You did have susceptibilities, like susceptible to fluoride. The lowest MIC that was on there.
Okay.
So I guess after we've discussed this a bit, what do you, or Mallory, you're still on Syndrome?
I see their side, but I probably still would.
Anybody else sending her in? Bo, would you have liked to go in, or would you have?
I would treat it as an outpatient first, and I will give the recommendation. If you feel worse, like vomiting, not tolerating pill, cannot take the pills, then go to ER right away. They will, yeah, that's what I would do. Or give her like a one shot IM ceftriaxone in my office, and then send her home. Maybe it might help. Yeah.
I like that one too.
Yes.
There's no right or wrong answer here.
No,
Yeah.
this is about just your clinical reasoning and why you make certain decisions and why not. Have you seen this before? Have you had to make this decision before?
I'm sure.
Yeah. I think pretty often we do have many UTI and then
I've had patients that like the first antibiotic didn't work, the culture came back, and I
Right.
switched them, but not necessarily like worsening symptoms of like fevers, chills, and all of that.
Mhm.
So I think I would have done outpatient if you did ask me. to.
yeah.
And again, there's no
Yeah.
right or wrong answer to this because you have differentials. You don't know what is going to happen. Your experience and hopefully the lecture that's going to follow is going to teach us not just probability or possibility, but likelihood as well. So taking that all into consideration and how the patient, honestly, your physical exam and how you think the patient looks, it takes, counts for quite a bit. So what would make you send her to the hospital? So what would you change out of either her disposition or her vitals or a combination of both that would say, all right, this person needs to go 100%, no doubt. I'm not comfortable treating this outpatient.
2 out of 4 stars.
So she was,
Still technically can do that.
I'm gonna get back to this, but in summary, we've gone from initial visit encounter, where we thought simple, uncomplicated UTI. We had a treatment plan. We had the patient follow up if there were any worsening. The patient did follow up. And now we're in the situation of likely complicated UTI versus pyelonephritis.